the water's released, the chance of getting an infection increases every 5%, 0.5%. So here's the case where it would increase even more, is when your provider decides to check your cervix, check you on the inside. That would actually more increase your chances of getting an infection. Best thing to do is really wait for contractions to happen, or in the case of you're closer to your due date, you may want to talk to your provider about other options to start labor or just to wait it out on bed rest.
So this is a doula who is giving medical advice to people about what to do when their water breaks before the onset of labor, which is PROM, P-R-O-M, or pre-labor rupture of membranes. It is not PROM or preterm, pre-labor rupture of membranes, unless it happens preterm, which would be less than 37 weeks. She's talking about PROM. So let's talk about PROM, P-R-O-M. PROM occurs in about 8% of all pregnancies. 50+% of patients who have term PROM or PROM will go on and go into spontaneous labor within a few hours. The most significant consequence of term PROM is intrauterine infection, and that risk will increase with the duration of rupture of membranes. So this doula is saying that the risk of infection increases 0.5%. is actually not accurate, because it increases with the longer of the duration of rupture membranes. And then there has been studies that have assessed the increased risk of infection. There's an increase at 12 hours, 16 hours, and the most significant increase is at 24 hours. Whereas he's getting this 0.5%, I don't know. That's why knowing exactly when or if your membranes have ruptured is key, which means getting it confirmed that membranes have ruptured is key, because that's when the clock starts as far as your chances for getting infected. The general approach to someone who presents with term PROM is a sterile speculum exam to confirm the rupture of membranes, and that may or may not require a cervical exam by the provider. A lot of times we don't even do it because they're going into labor or already laboring, and you just let them labor. And yes, digital cervical exams by anyone in the setting of rupture of membranes does increase the risk of infection. So even in term patients who have rupture membranes, the number of cervical exams should be limited. And this is directly from ACOG's practice bulletin on pre-labor rupture of membranes. A meta-analysis of 23 randomized controlled trials, including 8,615 subjects, found that induction of labor reduced the time from rupture of membranes to birth and the rates of chorioamnionitis or endometritis or both, and also reduced admission to the NICU for the neonate without increasing the rates of cesarean birth or operative vaginal delivery. There's another meta-analysis from 2021 of 9 randomized controlled trials, including 3,800 subjects with PROM that were induced with oxytocin at less than 12 hours versus at greater than 12 hours after membrane rupture. Compared with expectant management, induction at less than 12 hours resulted in less chorioamnionitis or intrauterine infection, less endometritis, which occurs postpartum in the lining of the uterus, less neonatal sepsis, less admission to the NICU, less time between PROM and delivery, a higher chance of delivering within 24 hours of PROM, and no significant differences in the rate of cesarean birth. So if you have term PROM and your provider recommends going ahead and getting labor started with Pitocin augmentation or Pitocin induction, depending on if you're contracting or not, that is a reasonable option. Or you can wait to see if you kick into labor on your own. That's also a reasonable option. And this is what ACOG has to say about patients choosing expectant management, meaning they just want to wait and see what their body does on its own. In the cases in which expectant management is chosen, given that nearly 80% and 95% of patients start labor spontaneously within 12 hours and 24 hours respectively, a period of 12 to 24 hours of expectant management is reasonable, as long as the clinical and fetal conditions are reassuring and the patient is adequately counseled regarding the risks of prolonged premature rupture or pre-labor rupture of membranes and the risk of infection. So expectant management is an option if the patient wants it and has been adequately counseled about the risks. Waiting at home on bed rest or just waiting is not the best thing to do, because number one, you need to confirm that you've broken your bag of water, and no, not everybody knows that. And number two, the clock starts then. So for anyone who wants to go in, please don't feel guilty for wanting to go in. It is perfectly reasonable, and please don't get medical advice from a doula.